sharing your slides. Hello,
Sure.
everyone. Good evening, everyone. Myself, Dr. Prashanth GOWDA, Secretary NNF Chapter Karnataka, would like to welcome all of you for today's most interesting presentation. And ultrasound is something which I love a lot. And today's topic we're going to have on basics of ultrasound and a few respiratory conditions what we see in neonates, and how ultrasound can quickly help us in identifying this problem, in differentiating this problem, and seeing real time the status of the lung, status of the pleura, and how the management can change with this mode of ultrasound. Followed by that, I'll be talking on the lines confirmation of central lines UVC, UAC, PIC lines, ET tube confirmation, and I'll be talking on pneumothorax. So since this topic and most of the participants who have been logged on today for the session, most of them are, few of them are practicing and few of them are not practicing, but definitely it would generate a lot of interest. And you will see how beautifully the ultrasound can change the way we look in our day-to-day neonatal management. So I would like to welcome for today's talk Dr. TUSHAR PARIK. He's the Chief Neonatologist at Motherhood Hospital, Pune. Dr. TUSHAR, on behalf of NNF Karnataka State Chapter, I would like to give you a warm welcome on behalf of our President, Vice President, Secretary, Joint Secretary, and Executive Board members and entire NNF Karnataka members. Thank you very much for accepting our request. And today's session will be moderated by Dr. Nilesh Rao. He is the Chief Neonatologist at Cloud9 Hospital, Bangalore. Dr. Nilesh, we would like to give you a warm welcome for moderating this session. Thank you very much for accepting. And over to you. I request Dr. Dinakar sir to introduce Dr. Tushar in brief, and then we can start the session. Over to Dr. Dinakar sir.
Yeah, Dr. Nilesh, are you there? I cannot see.
One more
Dr.
request
Nilesh?
for all the participants. I request all the participants to kindly mute your audio and video. Please do not switch on your audio and video till the session ends. At the end of both the session, we will open up for discussion. At that time, we can do it. You can unmute when we ask for it. Otherwise, please mute your both audio and video. It's a humble request. Please do not unmute. Please mute, switch off your audio and video. Thank you. Thank you. Over to Dinakar sir.
So can I take Dr. Nilesh?
Dr. Nilesh?
Yes, sir. Hi.
Can I see your face? Yeah. Yeah, Nilesh, please. I know that Tushar is very close to you and all of us, and he is a great speaker. Can you just go ahead and introduce, dear?
Sure, Dinkarji.
Yeah, please.
So, we welcome you all. We know that point of care ultrasound, the role of point of care ultrasound is ever increasing, and we are finding more and more applications in clinical neonatology to supplement clinical neonatology. Also, ultrasound as a field. So initially, I think it has been a recent thing. I think we are all learning recently. It has been prevalent in Europe for a long time, and they have been using ultrasound in neonatology for almost a decade or more in Europe. So I think we have two excellent speakers today who have been doing hands-on lung ultrasound for a long time now. I think it's introducing Dr. Tushar. So he's a close friend, and we have been meeting for quite a while. So we just 2 days back we had a discussion that we are unable to meet over conferences, but thanks to NNFK, Dr. Prashanth, Dr. Dinkar, and Dr. Kuturesh and the NNFK team, I think we are getting to meet and also getting to learn from him. So he's of course one of the experts in ultrasounds, in point of care ultrasound as well as in lung ultrasound. So over to Dr. Tushar. We are looking forward to an excellent session here, and followed by Dr. Prashanth GOWDA. So we are looking forward to these sessions. Over to Dr.
Nilesh.
Dinkar.
Nilesh, can you ask all the today participants to type the questions if they have any to send to the chat box, please.
Sure. So any questions,
Thank
please
you so much,
send us.
Dr. Nilesh.
I think we'll have a discussion at the end of the talk so that we don't interrupt and we'll continue the flow like after Dr. Tushar, Dr. Prashanth, and at the end we'll have we can have a discussion. I think we have experts here, Dr. Tushar, Prashanth, and of course Dr. Dinkar. So we'll have a very good discussion. So if you have any queries, please post it as a message and please listen to the talk. So please mute your phones and at the end we'll have a discussion. So over to Dr. Tushar
for a warm welcome. First of all, thank you, Dr. Nilesh. First of all, I would like to thank NNF Karnataka, the office bearers, Dr. Kutresha, Dr. Kishore sir, Bidri sir, and my close friends, Dr. Dinkara and Dr. Prashanth, to have me on this particular session. Lung ultrasound has been a very close topic to me, and we've been practicing lung ultrasound for almost 8-9 years now. We started point of care echo about 12-13 years, but as you know, the neonatal lung ultrasonography has started about 8-9 years. So in the next 30 or 40 minutes, I will take you through various aspects of lung ultrasonography. Many of these are skill-based, many of these are practice-based, and I'm not expecting everybody to understand and to get skills, but definitely this will generate a reasonable amount of interest. And I'll show you a few cases as we go along and how they point of care ultrasonography for the lung has made difference in management of the cases. Now, up until recently, we all used to believe that lung is a major hindrance for use of ultrasonography, and kind of lung ultrasonography or ultrasonography for chest and lung was kept out of vision for a very long time. And it was there in Harrison's textbook. But this is a reinvented science. We used to believe that air creates artifacts, and because of that, ultrasound beam cannot travel through air and it cannot travel through bone. And because of that, we used to always feel that lung is not the organ for ultrasonography. The air within the lung, it creates some kind of artifacts, and now we know that these artifacts are considered cornerstone in image interpretation of the lung. And the one person who was pioneer in this field is the one there in the picture, not me. It's Professor Lichtenstein, who works at Ambrose Paré Hospital in Paris. And I had a privilege to go there and clear my doubts and learn point of care ultrasonography for the lung ultrasonography from him. As you can see, the machine which he is using is a Hitachi, a very old machine. And many of these interpretations, what he has described, which are there in the textbooks and his journal articles, they are all, most of them, they are based on this new machine, on this old machine. So in a series of various papers, he described various signs on lung ultrasonography, each ascribed to a particular underlying lung pathology. And we will learn these various signs as we go along. But again, you have to remember that there are very specific ultrasonography pictures. Yeah.
Yeah, your slides are not visible.
Is it?
Can you, Can you please minimize and then again stop sharing and then start sharing? Yeah, because we are unable to see. And I request all of them to please mute your video. Please mute your video. I request all of you to please mute your video. Mute your video. Video and your audio. Please mute your video.
Can you see my slides now?
No. We cannot see your slide now.
No.
No.
Okay.
We cannot see.
I'll close.
Yeah, close and.
Yeah. Okay. 1 second.
Stop sharing.
Yeah.
And then restart sharing. Kindly open the PPT on the background first. Minimize your Microsoft Team.
Yeah.
And then
see this is pneumatic works. You don't see any mute. Small URS. Regular narrative.
Yeah, Dr. Tushar, you can unmute yourself, Dr. Tushar.
So, some other program to it. Yeah.
Dr. Tushar?
Hello.
Yeah, we're unable to
Yeah,
see.
we can see the slides. No? Can you see the slides?
No. No, we cannot see the slides. Singh, are you able to see the slides? Yeah. It has come now. Can you? Yes. It's coming. It's coming now. Can you? Yes. We can see now. We can see. Yeah, you can unmute and start your presentation.
So sorry for this slight interruption. So the lung ultrasonography, as I said, is a reinvented science, and the person who was behind this was Professor Lichtenstein. Professor Lichtenstein, as you can see in the picture, he works in this hospital in Paris, Hospital Ambroise Paris, and in a series of various studies, he described various signs on lung ultrasonography ascribed to various disease conditions. And as we go along, I will talk about various signs and how very clearly we can define certain conditions on lung ultrasonography where it is like an invaluable tool, and certain conditions where it can give you a good clue about management of the patients. Now this picture I've taken from Dr. Dinkara, and here as you can see, it's an underwater picture, and as you can see, there is water and there is this girl swimming. But as you can see, there are these white streaks. As you are seeing them, what is there in that streaks? There is nothing there. These are basically artifacts. As the light is traversing through water, it is creating those white streaks, and these white streaks are visible to eye, and these white streaks basically these are artifacts. And basically when we are talking about lung ultrasonography, we are going to interpret the images based on this artifacts which are created by the sound waves which are traversing through the tissue and the lung.
The basics, coach. TUSHAR coach, basics.
I think some. Yeah, I think some sound is coming. Are we talking about a future where a traditional handheld stethoscope will be replaced by a portable lung ultrasound device? Yes, probably. There are such studies, there are such questions being asked in the journal, and we are quite optimistic that with time, over a period of time, maybe traditional handheld stethoscope will be replaced by a portable ultrasound device. Now, when we talk about solid organ ultrasonography, what we see is a clear-cut solid organs which are there within the body cavity, and we need to know the spatial relationship among them and their movement and their blood supply and their overall anatomy. The image on the right of your screen, as you see, it's a common image, a normal image of a lung ultrasonography, and unless your mind knows what to see, your eyes will not see anything. But the beauty of lung ultrasonography is that here you do not need to know lung anatomy in detail, because here the interpretation of that particular image which is there on the right side of your screen will depend upon the artifacts that you're seeing. Now, looking at this image, you might find you can't make out anything, but as we go along, you will learn that there is something which one can learn from this particular ultrasound image of the lung. So because there is no anatomy involved, that way one can say that it is a very easy modality to use as compared to ultrasonography of any other part of the body. There are advantages of ultrasonography. Many of you are aware of this. It is a fast, real-time assessment of the lung. No radiation, multiple examinations possible. Sensitivity and specificity is much better than X-ray for some conditions such as pleural effusion, consolidation, interstitial syndrome. And I'll talk about this later on as we show the cases where you can yourself see that X-ray did not give us any answer. What is their underlying? But ultrasonography provided you the answer. It is also helpful for doing ultrasound guided procedures, and now it is increasingly used in the NICUs, as Dr. Nilesh said, that in last 9-10 years, it has become one of the mainstay of therapy in tertiary NICUs for certain conditions. So let's come to the normal lung. So if you see a normal lung, when you're doing lung ultrasonography, you should look, where should you concentrate? That is very important. So we assess the lung between the two ribs. And so as you can see here, this is the upper lip, this is the lower lip, and between these two is the lung. So we are going to concentrate when you're doing ultrasonography in this lung. Also, initially there is a chest wall, there is muscles, and below that there is a bright line, and below bright line is what the lung starts. And in this lung, you will see A line and B lines. Now, these are the two important artifacts which are created in the lung, and we are going to see them, concentrate them, and we're going to interpret our images based on that. Please remember, do not use algorithms to reduce artifacts in ultrasonography, because these artifacts are cornerstone for you to give interpretation what is their underlying. So what is a normal lung? See, normal lung, when you're seeing, you'll see something like this, which is the image which is shown here. The first bright transverse line, as you see here, which is also known as a pleural line. That is a line where the parietal and visceral pleura are situated, which is roughly about 0.5 centimeter below the surface. It is the most bright structure, first most bright structure as you see, or the brightest structure as you see, as you go away from the probe or towards within the tissues. And upper rib and lower rib, these are the upper rib and lower rib. So rib is a containing calcium or bony structure, and because of that it casts a shadow. So here there is a dark shadow, here there is a dark shadow. We are not going to look at this dark shadow. We are going to concentrate between these two ribs. This is the lung, that is which is seen. Now here this is a bright shadow of the rib, this is the bright shadow of the rib, and underneath this is the first bright horizontal line, which is the pleural line. Okay, now this is the pleural line, and below the pleural line you will see at equidistant horizontal lines. We are going to see what they are, but basically what you are seeing here is that this upper rib, this lower rib, and between the two is pleural line. All together they create something like bat-like structure, and therefore it is called as bat sign. So this is a bat sign of a normal lung, as you can see here. So over a period of time, the lung ultrasonography is evolved, and then we have come to know the various aspects. Now, can you see this video? As you can see in this video, so here I'll just show you. Here is the upper rib, here there is a lower rib. Between the two ribs there is a pleura, which and pleura there is a horizontal line, which is A line, which we will see later on. But just remember, this is the A line, and there is another A line which is getting cut here out of the vision. But then there is, if you increase the depth, you will see that. So this the bat sign, and what you see now is a lung slide. In real 3 dimension, in when the child is breathing, the movement of the between the two pleura, the parietal pleura and the visceral pleura, one pleura moves upward, the other pleura moves downwards, and because of that there is a lung slide like movement that you see. Now this is very important to see. If you are able to see lung slide, it means that between the two pleura there is nothing or maybe hardly any little fluid is there, which is normal, and because of that you see both lungs. Obviously if there is air or something, you will not be able to see the lung slide. So pat sign, then you're seeing lung slide. So these are the terminologies, but you need to know. So third thing is A lines and fourth thing is B lines. Now these are lines which are seen in normal lung and that we need to understand. So the first bright line, as I said to you, is a pleural line, and so it's a parallel line, and below the pleural line there are equidistant horizontal lines that you see, and they are known as A lines. Now these A lines are at equidistant below the pleura, and they indicate the presence of air. And they indicate basically they are throughout the lung fields basically, and B lines are the vertical lines. So these are laser like artifacts which start or originate from the pleura, and they go into various depth into the lung tissue, which will be seen on the ultrasonography. So these are the vertical lines starting from the pleura, and they go to the bottom of the screen, and they indicate presence of lung water. So very easy to remember. If A lines are there, that is because of presence of air within the lung, and B lines, if it is there, it is because of presence of water within the lung. And water and air within the lung along with the underlying tissue gives the artifacts. If you have more of water, you will have more of B lines. If you have more of air, you will have more of A lines and less of B lines. So these practicals workshops, but just to understand this, as I said to you, if there is more in the normal air where the air is more, then basically as the ultrasound beam traverses, there is interlobular septa, and there is reverberation. If there is more amount of water, if there is pulmonary edema, there is reverberation which is happening at a very short distance, and because of that, this small reverberation which is happening along the length of the ultrasound beam gives you comet tail artifact if it is a short one, and if it is more pulmonary edema or more water, then it will give a long, like a B line. Sufficient to say that basically more water, you get more B lines. Just to show, like normally in a newborn, 1 or 2 B lines in each lung field may be normal, especially if the baby is born. In adults, generally, if there are 2 or more B lines, they will not consider it as normal. But in the newborn, because the baby is just born and baby tends to have more amount of water as compared to the adults, 1 or 2 B lines are normal. If there are 3 or more B lines, then it is called as lung rocket in one lung field. And if they are confluent, if they are so densely next to each other, it is known as confluent B lines or even whiteout in the lung. So the normal lung ultrasound is, I think we need to unmute it because sound is disturbing.
Dr. Tushar, you unmute yourself. And please continue the session. Dr. Tushar, unmute yourself. Dr. Tushar, unmute yourself and continue the session.
Can you hear me now?
Yes. Go ahead.
Yeah. So basically, yeah. So normal lung ultrasound looks something like which is on the left side in 2D mode, and on the right side it looks like a sandy shore appearance. So when you see the lung ultrasound in 2D mode, you will see a first bright horizontal line as a pleural line, and that pleural line gives a reverberation artifacts all along, and that creates a equidistant horizontal lines coming from pleural line, and those are known as A lines. So this is a normal lung ultrasonography, and if you do a M mode there, because of the tissue which contains various amount of air and liquid, you will see a sandy beach appearance on M mode, and the structure which is above the pleural line, it being steady, it gives a plain horizontal line appearance. So this is basically a C shore appearance. So this is a shore and this is C. So C shore appearance, which tells you that it's a normal lung ultrasound. Now later on, Dr. Prashanth will tell us about sandy beach barcode sign, or C without sure appearance, and that is a sign of pleural pneumothorax, and that he will show later on. So again, this is just to show you how the normal lung ultrasonography will see. Normal ultrasound, this is a pleural line, and then there are few B lines which are seen, but this is horizontal, which is a sandy beach. This is C, and this is a shore. Now, how to do lung ultrasonography? So traditionally, lung ultrasonography is done in 4 anterior segments on either side. Plus, we do a PLAP point. PLAP point is something called as posterolateral alveolo-pleural point, which is somewhere situated here, just below the 4th point, where there is joining of diaphragm to the pleura, to the thoracic cage, and we screen that area specifically because many pathologies first occur there and can be easily picked up there. When we are doing lung ultrasonography, we have to ensure that the pointer of the ultrasound probe is facing cephalad, and we are placing the probe on the skin in a perpendicular fashion to the skin, and so that the ultrasound beam traverses through the tissue and gives a correct picture. We can use 7.5 Hertz probe. The 7.5 Hertz probe is the one which is provided with a dedicated pediatric machine, and that can be used for variety of applications including head sonography, 2D echocardiography, and the same probe can be used for lung ultrasonography. If you are using a higher frequency probe, it is better, it gives a better picture clarity, and one can use a transverse probe, and probe is held in longitudinal orientation with marker facing cephalad and should always be perpendicular to the body. This I already said. So basically, one has to ensure that if you are using, what type of probe you are using will show you the picture quality basically. Now let's go to the pathologic conditions which we face and how we see them in lung ultrasonography. Now we all know that in pneumonitis, it's basically the affection of the alveoli and the terminal bronchioles, and wherein which the alveoli filled with fluid, and there is increase in vascularity, and there is inflammation and thickening of alveolar walls. So this is what is pneumonia is, and how do we see them in the lung ultrasonography? So signs of lung ultrasonography, there are a variety of signs which have been described, and they are not exclusive. We have to remember that some of these signs can be seen in other lung pathologies as well. But again, you have to take everything together into picture and then do the underlying diagnosis. Now, when the pneumonia, as you can see, the common findings are the thickening of pleural line. So this, if you can see, normal thickness of the pleura is about 5 millimeter, less than 0.5 millimeters. So in case of pathologies, you will see, especially pneumonia, the pleural line is thickened and it is irregular and hyperechogenic. Also, something called as Shred sign you will be able to see within the lung parenchyma. So below the pleural line, there will be some hyperechogenic densities like the one which are shown here, and these are irregular lesions within the parenchyma which are suggestive of pneumonitis. So this is known as the Shred sign. Also, there is something which is described as C line. We learned about A line and B line. So there is something which is described as C line, which is specifically seen in pneumonitis. And these lines, if you see, there is thickened irregular pleura with, at a point where there is so much of thickness is there, it casts a bright vertical hyperechogenic stripe from this point. So this is basically a C line where it casts. So here, if you see on the real-time image, here you will be able to see a C line, which is a bright line which is coming here during breathing. So again, C line, if you see, that indicates that there is a subpleural consolidation which is giving the bright echogenic C line. Also, the lung fluid will be increased in those areas, and that may be because of the inflammation, and there will be more B lines. 1 or 2 B lines in lung field is normal. So if you are seeing 3 or more, then we consider it as lung rocket. It's just a descriptive term. Don't get worried why it is rocket, because they look flashy and like a laser-like beam which are coming from pleura. So can you see these lines which are coming from pleura, bright echogenic lines which are coming, and they are moving with each breath. These are the B lines. These are the classical B lines, as you can see. The A lines are the horizontal lines, and the B lines are the vertical lines coming from the pleura, and they go deep up to the end of the screen. These B lines indicate that there is underlying water which is more than normal. 1 or 2 B lines in each lung field is acceptable, but if it is more than that, that tells you B line. Is B lines exclusive to pneumonitis? Answer is no. But again, as I said to you, you have to take everything into account and then define what is the underlying problem. Now, as you can see, one can also see consolidation or tissue-like sign, it is called as, and even sometimes if you are lucky, you will be able to see air bronchograms. Now, please remember the air within the bronchi is seen as hyper-echogenic structure, and as you can see, because the air is a bad conductor of ultrasound beam, and as you can see, these empty channels, these are the bronchi, and as the air goes through them, you will see them casting a shadow downward. So these are the dynamic air bronchograms, and this sometimes you will be able to see around this segment of the lung there is free fluid, and that tells you that there is a thin pneumonic effusion in this particular patient. Also, one will be able to see increase in vascularity in the pneumonitis. This is again little subjective. However, if you are doing it every day, and then you will be able to see that particular segment of the lung which is close to the probe, there will be increase in vascularity on the Doppler examination. Also, you will be able to see thin pneumonic effusion as a black radiolucent fluid around the segment of the lung. So as you can see here, this is the lung, this is the kind of a pleural effusion, and this is the liver. And this is also known as a tissue-like sign. So the lung is seen as clearly as the liver, as if it is a tissue or as if like a liver-like tissue. Also in the flap point is the point where the diaphragm joins the thoracic cage, and this is the flap point. This is the posterolateral alveopleural point, and this is the point where a lot of pathologies start. If there is a fluid here, you will be able to easily see there is a consolidation. Many times this area gets consolidated early, especially in dependent part where the patient is bedridden, and many times you will be able to see starting of pneumonitis starting at this point. So this is like a specially.
Dr. Tushar, unmute yourself. Dr. Tushar, please unmute.
So then comes the lung pulse. Lung pulse is basically the movement of the heart which creates an impulse, and that you can see on the ultrasound beam. So as you can see here, here you are able to see the movement of the lung. This is the lung, this is the pleural line, this is a black structure, is a rib. So here's a rib which is casting a black shadow here, and under the rib line about ½ centimeter is the pleura. And this pleura, if you see carefully, it is moving up and down, and that up and down movement is because the heart is beating. Now this, to some extent, lung pulse can be normal, and it can be seen in M mode, it can be seen 2D image. But if you are seeing it excessively prominent lung pulse, it may be so that the underlying lung has become solidified or consolidated, that it is easily transferring the cardiac impulse to the surface. So put all these things together, one has to remember that ultrasound differentiates fluid better from differentiates fluid from consolidation better than chest X-ray, and therefore pneumonia diagnosis on ultrasound has a very high specificity as compared to X-ray. So this is very proven in very different studies that if you want to be very sure that what your shadow you are seeing on the X-ray is because of pneumonitis, ultrasound is the way forward, and ultrasound is a better modality to diagnose pneumonitis. However, there is a caveat: if the pneumonitis is in the deeper area, not close to the pleural surface, then you may be missing diagnosing pneumonitis just based on ultrasonography. So there are ultrasound correlates. Inflammatory edema within the lung will be seen as more B lines. If there is exudative filling of alveolar spaces, there will be patchy areas of Schredt sign. If there is exudative filling of alveolar spaces in a lobar pattern, you will see tissue-like sign. If there is increased vascularity, you will see it on Doppler measurements. If there is pneumonic effusion, you will be able to see it in basal areas, especially in flap point, anechoic space basically. If there is empyema, that is pus formation, you will see the effusion is thicker and there are debris within. I'll show you later. And in the terminal bronchial with fluid it is there, then you will be able to see the dynamic air bronchogram as the child is breathing. So these are various things that you can diagnose on lung ultrasonography, which is way more than what you can diagnose on the X-ray chest. Now coming to pleural effusion. Now suppose you have a child, you want to just diagnose presence of pleural effusion. These are the two areas where you are expected to do lung ultrasonography. The first one, two areas on both the sides. So one is anteriorly just below the rib, below the clavicle, and on either side at the flap point. So as you can see here, the anatomy. So at the flap point, this is the chest rib cage. Here there is a diaphragm. Under the diaphragm there is liver, and this is the hypoechogenic structure or space which is seen is a pleural effusion. Similarly, on the left side there is a spleen, and you will be able to see the fluid within the pleural cavity. And then there are various names which are given. There is a cord sign because it looks like a cord there. If you're seeing debris within, there is known as a plankton sign, which are not visible on chest X-ray. And in case of a breathing child, spontaneously breathing child, you may be able to see a sinusoidal pattern. This is the pleura, parietal pleura and visceral pleura, and between the two, because the lung is kind of breathing, and because of that you will see a sinusoidal pattern, especially in the aorta. So these are just the names which are given just to tell you that there are various names which are there to describe the presence of pleural effusion. Now, just to show you, there is another sign which is described as a jellyfish sign. Again, here to tell you, this is kind of a diaphragm. The brightest structure which is going is diaphragm. Below the diaphragm there is liver. There is a fluid here, and this particular segment, as you can see, looks like a jellyfish. And this jellyfish is basically the segment of the lung which is collapsed and which is moving with the breaths. So this is something again described as a part of pleural effusion in some patients. Also, something as spine sign is described. Normally, when you are doing lung ultrasonography through the flap point, you will not be able to see the ribs, the spine so easily, because this segment of the lung, which kind of intervenes between the two, has air, and air does not allow you to see through, and because of that, you are not able to see the spine so clearly. So, if you are able to see spine so clearly, then this is a kind of spine sign of pleural effusion. So, these are various names which are given to describe. Don't get kind of worried with the names, just to try and understand the background behind them. Again, these are the pleural effusion with septi. So this is the pleural effusion which you can see. Also, sometimes you can see the septi which are moving with pleural effusion. Again, this is telling you that this is the empyema which is getting consolidated, and there are septi formation, and this patient probably will require VATS, or may require some decortication. This is a kind of a serious, more severe condition. Now, I was talking about the plankton sign. As you can see, this is the effusion which has got particles which are moving with breaths. Now, this is basically a plankton sign. So again, accuracy of sign for pleural effusion, consolidation, intestinal syndrome, it's a fairly high accuracy of lung ultrasonography as far as the diagnosis of these three important conditions is concerned. So we need to know where exactly ultrasonography will help you in interpreting basically for the lung. Those who are interested, there is international evidence-based recommendation for point-of-care lung ultrasonography, and this recommendation is for all ages. There is recommendations for adults, pediatric age group, and even for neonatal age group. There are separate recommendations which are given, and this is there for everybody to read. Professor Lichtenstein is one of the important committee member in this, and one should read this, and it can be used in daily practice. So just summarizing, lung ultrasound is, I'll come to the cases, but sliding movement of the visceral and parietal pleura will be lung slide. There is something called as A lines, which are horizontal equidistant reverbation lines. B lines are the vertical projections from the pleura. They indicate presence of water. Alveolar consolidation will be seen as a tissue-like appearance of the lung, and pleural effusion will be seen as unechoic free space above the diaphragm. And septi will indicate that it's an empyema, and it is basically forming septi. So now I'll take you through a couple of cases where I've used it and found it very helpful. Now just take the example of this 23-week-er 45-day-old neonate. The baby was on so far high frequency ventilation because baby had a lot of ongoing issue. As you can imagine, 23-week-er goes through various things. Now at day 45, there was slight deterioration. Baby had ongoing issues of sepsis, anemia, hemoglobin was 9. Baby had 3 courses of failed medical therapy for PDA, and baby had NEC, and the baby is recovering, and baby was receiving total parental nutrition. There is a central line, and baby was worsening on the ventilator. Mean airway pressure of 14 and delta P of 35. FID requirement was 70%. So the baby was critical. Baby was sick and was having a lot of ongoing issues plus deterioration. And we did an X-ray. X-ray was something like this. Now, this X-ray, you can't make out anything. Both the lung fields are appearing white. The heart and lung differentiation is not there. agreed that it's not a centralized X-ray, but still you can't make out what it is. Can it be a consolidation? Probable. Can it be a collapse because maybe there is a crowding, but it's a rotated X-ray? We can't be sure about that. Is there any underlying effusion on either side? Because you can't see the cardiothoracic or costophrenic angles. And can there be pulmonary edema? This baby is having anemia, PDA. Can this be a pulmonary edema? Or can this be pleural effusion because the PICC is in place and it has leaked and it is leaking PPN in the thoracic cavity? So these are the various questions we had. So we did a point of care lung ultrasonography in this baby, and as you can see in the axillary lung fields, there were confluent B lines. Confluent B lines on to lung rockets. Lung rocket means more than 3 B lines there in the lung fields. Also, there were areas where there was anterior lung fields, there was areas of consolidation and presence of Schratt sign, and there were horizontal air bronchograms suggesting that the underlying lung was some amount of collapse and some amount of consolidation was there. So basically what it told us is that definitely there is no pleural effusion. There definitely the lung, there is some element of consolidation, but it is a partial consolidation, and there is an element of fluid overload or hemorrhage or pulmonary edema, which may be secondary to the PDA, anemia, or because of the infection which is there. So in this scenario, we increased the map, blood transfusion was given, antibiotics were continued, and X-ray was done after 24 hours, which showed some amount of opening up of the areas of the lungs which were predominantly having pulmonary edema. And as you can see, there was a air bronchogram and consolidation which was there in the right upper lobe. This baby is done well at 9 months. Baby is following is more than 1.5 years now. Then case 2, again this baby is 2.7 kilo, antenatally diagnosed diaphragmatic hernia. Baby had severe hypoxemic respiratory failure since birth, high frequency ventilation, inotrope, sildenafil. As you would expect a baby with huge congenital diaphragmatic hernia. Baby was stabilized a little bit and then was operated on 3rd day. And post-operative, baby was doing okay, and baby was on SIME mode day 4, steady recovering. FiO2 had reduced to 30% by day 5, and then on day 6 we stopped sildenafil, and then we saw that on day 7 onward baby had gradual increase in oxygen requirement to about 60%. Now this baby was otherwise okay, but then there was increase in oxygen requirement to the 60%. So we thought whether it is related to rebound of pulmonary hypertension, or maybe there is underlying pneumonitis which has happened, or is there anything else. So we did a lung ultrasonography in this baby, and in the right upper lobe you could see the crowded air bronchograms. So as you can see, these are the air bronchogram, but there is a crowding, and especially in the right upper lobe. So this basically was suggestive of right upper lobe collapse, and this was again this was confirmed later by the this thing. And so this baby had a right upper lobe collapse, and we did a physiotherapy, postural drainage, and this lung opened up. So how do you differentiate between collapse and consolidation? Basically in collapse, the bronchi, they form an arboriform pattern, and there will be static or fluid bronchogram, and there will be crowding basically. As compared to pneumonia, there will be tissue-like ecotexture and dynamic air fluid bronchogram, and there is no crowding basically.
Tushar, please unmute yourself. Tushar, please unmute yourself. Unmute. Yeah.
Now we have to remember at this point in time, a lot of lung ultrasonography that we are doing, it has come from adult medicine. Professor Lichtenstein is a adult medicine specialist, and subsequently studies which have happened in last 20 years, most of them they are in adult medicine, and then they have come to the pediatrics, and then they have come to the neonatal. There are so many neonatal conditions which are specific to the neonate, and unfortunately they have not yet been characterized by lung ultrasonography. So many of you who are interested in doing studies on lung ultrasonography, there is a lot of scope. Now, neonatal RDS is again a condition which is very common. There have been studies on this, and what it has been shown that neonatal RDS, how it is seen on lung ultrasonography, there is a pleural thickness is there increased, and the pleura is thickened and irregular, and there is confluent B lines, almost tissue-like appearance which can come up, and white lung or alveolar interstitial syndrome, it is because of that, and A line disappearance is a very important thing which commonly seen in neonatal RDS. And similar appearance which is seen in all our lung fields. This is very important, that it is not gravity dependent. It is the underlying pathology of the lung which shows up like this, which is uniform in all lung segments. If it is not uniform, then one has to think about presence of TTNB or presence of pneumonitis, and then other differentials are there. As I said again, all these signs are not specific for a particular disease condition. So you have to again take everything into account and make a decision. As we know that amount of air within the lung, when it goes on decreasing, the normal lung which is appearing black will start showing more and more number of B lines, and A line will start disappearing. And when it becomes a completely consolidated, you will get a gray tissue like appearance of the underlying lung. Now, for neonatal TTNB, transient tachypnea of newborn, a condition which is described, a specific ultrasonographic finding which is described as a double lung point. Now, why it is called as double lung point? You place a transducer on the baby's chest laterally, and what you see is that the gravity dependent segments of the lung will have more amount of water, and the top segment has less amount of water. And this is because of transient tachypnea of newborn. So the lower lung, so it is as if you are seeing two different lung fields in the one image. So if you see the lower image, lower half of the image, it is all B lines, confluent B lines, thick confluent B lines, or whiteout kind of pattern. But the upper lung fields, you are seeing some of the A lines. I have some pictures where we have done it to use. So if you see real life, you will see that the B lines are more confined to the lower lung segments, and even if you see here, there is appearance of A lines here. So I'll show you the images which are there. So this baby is 36 weeks, diabetic mother, and it was LHCS, fetal distress was there, 3 loops of cord were around the neck, no resuscitation required, but baby had moderate distress at birth, grunting, subpostural recessions, oxygen requirement was about 80%. There is no evidence of shock. So this baby was born to diabetic mother, possibility of RDS is there, and possibility of pulmonary hypertension, and those kind of things were there because baby was requiring high amount of oxygen. So baby came to the NICU, and after the baby came, we did the lung ultrasonography. One second, this is taking a little time. So in the lung ultrasonography, we saw that there was a segment. One second. Yeah. So if you can see it, can you see it? Yeah. So if you see here, this particular lung ultrasonography, if you see this area, there are A lines, obvious A lines which you are seeing in the lower segment in the because this is the it is put it that way. So upper segments, these are A lines, and if you see the lower lines, there are B lines which are vertical lines. Okay, again telling you this is like a double lung point. Double lung point telling you that basically this is not neonatal RDS, this is a transient tachypnea of the newborn. Again, you do plap point. As you can see in the plap point, there are confluent B lines telling you that there is a lot of water. These are more of fluid shadows, and again telling you that this is a transient tachypnea of the newborn. We did X-ray anyway, and that again confirmed that basically it was a TTNB. So there are studies now, people who want to do research in this, there are studies to assess the lung water, and extravascular lung water is a common problem seen in sepsis and ARDS, and B lines are a surrogate marker of acute interstitial syndrome, and confluent B lines represent alveolar edema. So people have devised lung ultrasound score based on the number and distribution of B lines versus transpulmonary thermodilation technique, which is basically a gold standard to assess the extravascular lung water index, and they were compared, and they were done in 50 ICU patients, and the score was done in 4 areas of the lung. So depending upon basically number of B lines you see in that each space, they were scored from 0 to 8. Okay, and this was the scoring given to number of B lines you see in each lung field in that 4 areas, and therefore maximum score was 32 and lowest score was 0. And based on this, basically one can they found out that this extravascular lung water index had a better correlation with so lung ultrasound score had a better correlation with extravascular lung water index, and this CVP or X-ray was not a good surrogate marker of extravascular lung water. So again, one can use that. This is the study done by us in KM Hospital. This by Dr. Anukul, and we did screening of 92 neonates who had preterm, who were preterm and had respiratory distress after birth, and 61 were diagnosed during the course of their illness as having RDS. So what we found out is that lung ultrasound was able to diagnose almost 80% as against 70% cases on chest X-ray. So it had a better diagnostic efficacy, and lung ultrasound diagnosis had a better kappa correlation than chest X-ray basically for diagnosis of RDS. And the most common lung ultrasound feature was pleural line thickening and whiteout lung fields. And more importantly, this B line score of 40 or above had a sensitivity of 74% and specificity of 90% for diagnosis of RDS, and it correlated well with severity of neonatal RDS and need for surfactant therapy. So we showed that this lung water score had a better correlation with severity of the disease as well as need for surfactant. Now, another important application of lung ultrasonography is for recruitment of the lung. Now, as I said, more amount of air, you will get less B lines and more A lines. So, it's a ventilation, lung recruitment maneuver is a ventilation strategy where that resolves the lung collapse by brief controlled increment in airway pressure, while PEEP is kept. So, if you see, so this is the piglet model. So this is mean airway pressure is gradually increased, and as you increase the gradually mean airway pressure, the oxygenation improves, and here you can at each state ultrasonography, and then you start reducing the pressure till the time it shows start showing collapse. So till the time you see start collapse of the lung, you increase the pressure by 1 to 2 centimeters of water and keep it there and ventilate the baby at that pressure. So that will be the ventilating just above the opening pressure of the lung. Now again, this is experimental. It has not been tried in the neonates, but again, one can decide about opening and closing pressure based on the lung ultrasonography, because as you see, there will be disappearance of B lines, and the lung will open up with increasing pressure. There are studies in the ER they have done, and this on the left side are the image where the PEEP was 0, and as they increase the this is so bedside ultrasound for increasing end expiratory pressure. So the left side is the one with the 0 PEEP, and the right side where they increase the PEEP to 15, and they showed that the B lines disappear and A lines appear. So again, there is a blue protocol where they have shown that lung ultrasonography can be easily taught to non-ultrasound experts for 5 years of theoretical training and 10 supervised examinations, and they've shown that they can be taught to identify patterns. A pattern, B profile, C profile, and A profile is simply for air, B profile is for simply for fluid, and C is mainly for consolidation. So this is air profile, A profile, B profile is more of B lines, and C profile is more of a consolidation profile. So this is a simple thing which they have shown that can be taught to non-ultrasound experts, and they can be taught. And so again, telling us that it is not very difficult, and that can be shown with a fair high sensitivity and specificity. People have used lung ultrasonography daily in admitted ICU patients to diagnose pneumonia early, and again it has become an important modality. We have been using it for diagnosis in a collapsed and unwell patient. If there is a sudden deterioration of a patient in the NICU, we do screening of the patient for the heart, brain.
Tushar, please unmute yourself. Unmute yourself. Dr. Tushar, please unmute.
There is a lot of kind of test attributable available evidence is there. However, in clinical practice, we need to still get more evidence, and so that we can show that lung ultrasound will have impactful use in the neonatal practice, and there is a lot of scope for doing more studies. So summarizing, ultrasound has a reliable sensitivity and specificity to diagnose consolidation, effusion, collapse, and RDS in neonatal population, and we have been regularly using this, and more with more and more confidence now. It has a potential in guiding lung recruitment and optimal PEEP. This is again still experimental, but we can explore this, and with time maybe we'll become more proficient. And it can have give an idea about extravascular lung water, which we know has a good correlation with sepsis and mortality. Along with functional echo, it will give important vital hemodynamic information to optimize care in a sick patient. So thank you very much for a patient listening. If there are any questions, I'm happy to answer them after Dr. Prashanth's talk. And thank you very much.
Yeah, thank you, Dr. Tushar. It was a wonderful presentation, and we will take up question later. So I request you to stop sharing the presentation.
Yeah.
Dr. Nilesh? Dr. Nilesh?
Thanks, Dr. Tushar, for an excellent presentation. I think very extensive and comprehensive. I will request Dr. Prashanth GOWDA to kindly start his presentation. I think it's the practical aspects of it. So the utility of ultrasound in determining the position of lines, and also the excellent utility in detecting pneumothorax. So now, even if we compare X-ray, the turnaround time for an X-ray takes a lot of time to detect emergencies like pneumothorax. So I think ultrasound is the way forward now. Over to Dr. Prashanth GOWDA for his talk. Dr. Prashanth?
Yeah. Thank you very much. Am I audible?
You are audible, Prashanth.
Okay.
I can hear you, yeah.
Yeah, thank you very much. So we're going to talk, today I'm going to talk on the most important aspects of point of care ultrasound. That is, using the ultrasound, how we can actually identify the position and exact position, and the way we do it, the real time, how we can see EDT, insertion, UAC, UVC, PEEK lines, and ultrasound guided diagnosis of pneumothorax. I got excited with all this, doing all this. I'm sure my presentation will make you excited and start using at your practicing place. So at the outside, I have personally met and I've spoken to him. Very simple guy, Dr. Daniel Lincolnston, who's been called as a father of point of care ultrasound. He started in 1975. I have spent few days, maybe a week time with him, weekdays, maybe 7 to 10 days. But maximum ultrasound I've learned from a man who is standing next to me, next to Daniel Lincolnston, that is Dr. Dinakar sir. So I would like to dedicate today's my talk to these two living legends who have actually helped me in infusing the ultrasound interest, motivation and passion, and because of which I bought my own machine. So coming to the requirement of first topic, it is very simple, and I'm going to put a lot of videos. I'm going to show, go a little slow. I might take around 45 minutes to 50 minutes, but trust me, you will enjoy it, and I'm sure you will get excited and you'll start using the ultrasound. So before we go into the ultrasound intubation, ETT placement and position, you need to have a brief idea about anatomy of the neck. And what probes to use. You can use any probes, preferably high frequency linear probe, where you get to see a full length of neck. So this is me, who's doing ultrasound of the neck. And slide it very carefully and place it over the suprasternal area first, and then you can swipe it upwards. That is the easy way to do it. Take a probe, the marker should be on the right shoulder of the baby, and then you place it over the suprasternal area. This is the image what you will get when you see. It looks like a tiger blinking, the two eyes with the tiger thing. So I'll tell you how to diagnose this. What I'm showing in a finger is the trachea and tracheal shadow, and I'm trying to show you the how does with linear probe on a transverse section how our neck looks. So if you are seeing first with this particular video, you won't understand anything. Let me move to the next slide. At the end of the thing, I'm sure you'll understand it better. So this, when you place a probe, this is the probe and V is the marker. This is I've taken from the same baby. This is the skin, what you're seeing when you place the probe.
Dr.
Then you
Prashant,
have a
see the
thin platysma muscle, fat. Then you have a neck is divided into three parts. One is the visceral part. We call it, inside that you have thyroid gland, thyroid cartilage, cricoid cartilage, and your trachea. Then you have your
Dr. Prashant, we cannot see your slides.
There's a problem with the page.
And anteriorly what you see is the sternocleidomastoid muscle. Posteriorly you see the muscle.
Prashant
So
can't see your
going
slide.
next, you need to have a brief surface anatomy. Adult, I've put an adult picture of backbone, thyroid cartilage, trachea, and tracheal notch. I'm sure you're able to see this. So I'm played with
Prashant sir, your
how
slide
the
is not
inlet
moving.
of
Prashant sir, your slide is not moving.
1 second.
We are not able to see your slides, Dr. Prashant.
Still your slide is first slide, sir.
Is my slide moving, Dr. Nilesh? Dr.
Sir,
Nilesh,
not happening.
is my slide moving?
No,
The slide is not moving, Prashant.
Ultrasound, teaching.
Not visible, sir. Not visible.
Dr. Nilesh, can you hear me? Prashant, is my slide moving?
No, sir. No, sir.
No.
Not moving. Voice is heard. Okay.
Voice is also breaking, sir.
Yeah. Is it fine now?
We can see now, Prashant.
Yes, sir.
We can see.
Can you hear me?
Yes, sir. Yes, sir.
Can you hear me? Can you hear me?
Yes, sir. We can hear you.
Director, sir.
Sir, we can hear you.
Prashant, we can see you. Continue.
Am I audible?
Yes, sir.
You're audible.
PPT is not coming.
Prashant, continue.
Am I audible? Am I audible?
Yes, you are audible.
Sir.
Am I audible now?
Prashant, you are audible. Continue.
We can hear you, Prashant.
Sir, Dinakar sir, am I audible now?
Yes, yes.
Yeah, continue.
Am I audible? Am I audible?
Sir, you are audible.
Prashant, we can hear you. We cannot see the slides now.
Can't see the slides.
Sync ಕೇಳಿಸ್ತದೆ ಮಾತಾಡ್ತಾ ಬ್ರೇಕ್ ಆಗ್ತಿದೆಯಾ ಇವಾಗ ಕೇಳಿಸ್ತಿದೆಯಾ ಸ್ಲೈಡ್ಸ್ ಕಾಣಿಸ್ತಾ ಇದೆಯಾ ಹೌದೌದು It's fine now? Okay. So introduction yeah so the next thing is this is the slide what you get. So I request you to in case if voice is not clear or if you are unable to hear me, please let so that I will adjust accordingly. All right. So this is the thyroid cartilage. This is the surface anatomy. I had bone, thyroid cartilage, cricoid cartilage, and tracheal notch is what we see now. What we're seeing right now. Is my voice audible? Singh, can you unmute and tell me whether it is audible?
Yes, sir. Yes, sir. You can carry.
Yes, sir.
Singh?
Yes, sir.
Sir, carry on.
Can you unmute and tell whether it is audible, Dr. Nilesh, Dr. Dinakar sir?
Sir, carry on, sir.
Yes, we can hear you. Yeah, please carry on.
Singh? Is it?
Yes, sir.
Am I audible?
Yes, sir. You are audible. Start, sir.
Yes. Okay. So, yeah. All right. Fine. Sorry. So this is the surface anatomy. I had bone, thyroid cartilage, cricothyroid cartilage, cricoid cartilage, and trachea. So I'm going to play a video now. How the inlet of the trachea, the inlet of larynx looks like. So this is the way it looks. You can see here how it looks. So you have a green color one, that is your
We can't see the slides.
You have this eglottis,
Prashant,
then you have aretinal cartilage.
Prashant, we cannot see the slides.
Cartilage, you can observe here.
Can't see the slides.
Hello? We cannot see the slides.
Slides are not seen, sir.
Huh? I don't know, you just connect me. Slides are not visible.
No, slides are not visible. Please share them. Huh?
It's fine, no more. Come on. What's happening? Sure. Network. Yeah, all right. Yeah, I think slides are visible now. Yeah. So,
Yeah, just continue.
Of larynx, epiglottis. Green one is your iod bone. This is your thyroid membrane. Then you have thyroid cartilage. This is how it looks like when you're intubating your epiglottis. You lift the epiglottis, and then you look at uh, 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 the vocal cord, and then you place your ET tube. So I'm sure it's very clear what you are looking at and what you are trying to put when you're intubating. So two things you observe here, that it should enter into the trachea. Second thing is it should uh, be in position so that it is not too deep, so that it does not ventilate only one lung, it ventilates both the lungs. So this is how it looks like vocal anatomy. You have epiglottis, you have true vocal cords, false vocal cords, arytenoid cuneiform, then arytenoid cartilage, coniculate cartilage, and this is your piriform fossa. Here, foreign body can get stuck. Anyway, we'll not go into that. So use of auscultation technique to identify the reliability and to identify the position of the ET tube is hardly 60 to 65% sensitive. As I said, when you place a probe, the marker should be on the right shoulder of the baby. First, you place it on the suprasternal area. Next, in the baby's head. It is very difficult to identify when you are starting your ultrasound scans. So try to place it in the suprasternal area. Swipe it upwards. Initially, when you swipe upwards, you see. So we'll go one by one. How does it looks? So basically, when you, as I said, divided into
requesting everyone to kindly mute other than the speaker.
Thyroid gland. On either side, you have your vessel, that is a vascular part, and posteriorly it is a vertebra, vertebral muscles. What you see. So here we have taken a section. When you place a probe horizontally across suprasternal notch, as marked here, this is how it looks like. You have your skin, you have your thin platysma muscle, then you have your soft tissue on either side. You can see the sternocleidomastoid muscles. Then you have your thyroid gland. This is your thyroid gland. I'm sure it's very clear. And then you have your thin crescent-like structure. That is your trachea. And because it is there in the trachea, it does not pass through. This is how it looks. And here you can see esophagus. Esophagus can be on either side, left or on the right. Clear? I hope the structures are very clear. This is we have taken a cricoid cartilage. You can think that this is your tracheal ring, but when you look at the cricoid, it is more like a oval shaped, little thicker than your trachea. But most important thing when you're doing point of care ultrasound is to see the position of the ET tube, whether the tube is in trachea or not. So this is the brief anatomy which this is the cricothyroid membrane, how it looks. So this is how the thyroid cartilage, you can see the difference in the shape, how it looks. This is your thyroid cartilage. This is your sternocleidomastoid muscle. This is your vocal cord. And this is your arytenoid cartilage. So if you take a longitudinal section, when you place it vertically or a sagittal section, this is how it looks like. Tracheal rings looks very tiny. And then you have your oval shaped cricoid cricoid cartilage. So this is how it looks like. And thyroid cartilage is little bigger when we do. So this is how it looks like. When you place a probe, you can see this is your trachea. The moment you put it, this is exactly it looks like. You have skin, soft tissue, and this is the trachea. Because of the air, you see tracheal sign or comet tail appearance or goose sign. Basically, you don't see anything after this. You see an inverted U and then you don't see anything. Either side, what you're seeing is a vascular compartment. In ultrasound, it exactly looks like this. You can clearly see the trachea. On either side, you can see the vessels, and this is your tracheal sign or single goose sign. Now, so when you place a tube, three things can happen. Either it can be in position where both the lungs are ventilated, it can go a little deep into the endobronchial site, or it can go into the esophagus. So when we do, that's why we need to do tracheal ultrasound, and as well as we need to do lung ultrasound. Tracheal ultrasound will tell us the position, whether it's in trachea, and lung ultrasound will tell us whether both the lungs are being ventilated equally or not. So what are the things which we look at? So when you place a probe, you get this image, inverted U shape, that is your trachea, and this is called comet tail appearance. So you see one single comet like this. So if you are placing it in esophagus, if the intubation is in esophagus, you see double comet sign. I hope it's very clear that you see a comet tail, one comet tail here, and the second one is your another comet tail because of esophageal intubation. So it's very easy. Once you do it, it's very, very easy. So this is in the sagittal section or the vertical section. When we do it on the lung. So here you can see that there is tube which is placed. So because of the tube placed, you can see the lung sliding sign. Till now, Dr. Tushar was describing on the lung sliding what exactly it is. This is your rib shadow on either side, and this is your pleura. So you divide lung ultrasound into 3 zones. Above pleura is zone 1, your pleura is zone 2, and below pleura is zone 3. This is for your understanding. I'm dividing into 3 zones. So you can see sliding of lung. So when tube is in place, if you do on both right and left lung, you see equal lung sliding. I'm sure by now you are aware what is equal lung sliding. At times, when tube is too deep, you can see a lung sliding on the opposite lung as well because of the retroflow of the air. So, but you cannot take lung sliding alone as a marker for bilateral air entry. You need to look at other aspects as well. In radiology, it is a dictum that you cannot diagnose anything in one plane. You have to go for a different plane, at least 2 to 3 planes. So this is how it looks like in the video. You can clearly see the shining movement of the pleura on one side, and there is an M mode. This is the pleura. This is the pleura, and above this is your soft tissue and muscles, and below the pleura, this is your lung parenchyma. Suppose if pleura is also moving and lung is also moving, lung parenchyma is also moving, you get this is like a water, and this is like a sand. That's a seashore appearance. Suppose if lung is not moving because of air or effusion, then you get to see this barcode. So nothing but you only see the above pleura lines, which is moving. Below pleura, it is not moving. That is what it means. Loss of shore. The sand is lost. So I'm sure it's very clear what is lung sliding. Why lung sliding is important? When you intubate, you do a tracheal thing, look for the position, single goose sign or single comet tail sign, or if it has gone into the esophagus, you see the double goose sign or a double comet tail sign, and then you look at the lung sliding on both the sides. So this is how it looks like. There is something called as lung pulse. Suppose if pneumothorax is there, you don't get the lung pulse. Lung pulse is nothing but with every beat of heart, your lung parenchyma, lung pleura, and the structure moves. So that can be recorded. So this is your no lung sliding, plus even in consolidation, differential diagnosis for lung sliding is pneumothorax, consolidation, atelectasis. So in all this thing, how do you differentiate? When you place a probe, you don't see this lung pulse in pneumothorax, whereas in other condition, in consolidation and in other condition, you see this lung pulse when you put in M mode. I'm sure you can clearly see these are the arrows which suggest, which are equidistant, which is pulsating with each pulse. This is your M mode. So you can see with each pulse, lung pulse seen in M mode. It may not be obvious in your regular 2D mode. In consolidation in pneumothorax, you might get confused. So when you put in M mode, you'll be able to see that clearly differentiates from pneumothorax to rest of the condition. In pneumothorax, you don't see that. That will come later. So when you intubate, whether if it is inside the trachea, you will get single comet tail. I'm sure all of you are very clear what is single comet tail. Then you also see your bilateral presence of lung sliding. Single comet tail, bilateral lung sliding. It's in trachea and it is equal. Endobronchial, if it is too deep, you get single cometal still because the tube is in trachea, and you get unilateral or diminished lung sliding on one side and presence of a good lung sliding on the contralateral side. That is endobronchial. If you see double comete sign or double goose sign, then and without lung sliding, it is in esophagus. So you have to immediately take out and put it. I've got few videos as well, or real-time videos how we put it. This is how you place the probe. The marker is on the right side of the baby's shoulder. Then, as I said, this is your visceral part, which contains your thyroid gland, trachea, esophagus, and then this is your vascular part. See, you can see clearly here, this is your trachea, then this is your esophagus. Now let us intubate and see where exactly. Kindly look at the esophagus part. This is your one comet tail sign, Now we are intubating and we are seeing. Can you see now two comet tail? You can clearly see two comet tail. So this is an esophageal intubation. I'll show it again. So this is your esophagus. The tube is put now. You can see here. In real time, you can see that it's in esophagus. You have two tracheas now. So two tracheas is not a good sign, or two comet tail sign, or two goose sign. You can call whatever you want, but you need to understand that there cannot be two tracheal sign. If it is in esophagus, you see this. So now we are rooming from esophagus and we are trying to put within the trachea now. So kindly see how it is moving, yeah, and you can closely see the esophagus as well. There is no double goose sign, there is only one goose sign. So you can see here. So this is how exactly it looks like when you do real-time ultrasound with the when you are intubating. So this is how it looks like in transverse and longitudinal section. Your ET tube, you can see the reflection here, two lines reflection here. On the longitudinal section or sagittal section, you see it as two thin lines, the ET tube. This is the longitudinal section which I was talking about. You have your tracheal rings, you have your oval shaped cricoid cartilage, and you have your thyroid cartilage. So this is the real-time video. Closely observe. You're going to place the probe on the suprasternal area. You see the tracheal sign, and you can see esophagus. It's on the left side here. You can see here. So now they have intubated in esophagus. You see one goose sign, and you have another goose sign. Now we are removing it from the esophagus, and we are trying to put in the trachea. So you can see the movement here. You can see the movement. You can see this reverberation and line. There was one single line. Now you can see the double line. This is how it looks like when you intubate with video laryngoscope and ultrasound of the neck. So if you freeze the image, this is your trachea, wherein you have ET tube is in place, and if you have put the NG tube looks like a small dot. This also helps in identification. At times there are pitfalls because of NG tube when it is placed, it can falsely show the tip of ET tube because of reverberation or reflection. So that is a big thing that we will talk later. This is not scope of today's talk. So I hope most of you are very much convinced that it is very easy to actually put it. This is few images which I have taken on the baby. You can see a vocal cord here. This is your vocal cord, and this is your cricoid cartilage appears like two dots here, and then this is your thyroid cartilage, and this is your thyroid gland. So here also you can see. You can see here, I've pulled it below the vocal cord. Yeah. So this is how it looks like. Now coming to the tip of the ET tube, where it should be placed. So this is your arch of aorta. You can say innominate artery. You have your left carotid and left subclavian. In between innominate artery and your left carotid, this is your arch, which is maximum peak. From this point, it has to be 0.5 to 1 centimeter, the tube. So when you go with your suprasternal view of aortic arch, from the aortic arch, it has to be 1 centimeter, within 1 centimeter from the peak of the arch, that is between your innermost artery and left carotid artery. From here, the tube should be placed here. If it is anything less than 1 centimeter, it is too deep, you have to pull it up. So here you can see, ET tube is placed. Let's do an ultrasound and check how exactly it looks. You can see here, this is too deep. It is less than 1 centimeter from the arch of aorta. It is less than 1 centimeter from the arch of aorta. So this is the tip of your ET tube. 2 lines, what you are seeing is the tip of your ET tube. So here you can see both gastric tube and you can see the ET tube. Your arch of aorta and then your artery, you can see here, and then this is the position you need to keep. So let us have a small mini quiz. I'm sure most of you know. We are moving on to the next topic, that is UVC and UAC. Can anybody tell me what is the normal level of insertion of UVC quickly? 1 at the level of diaphragm, 2 above the diaphragm, 3 atriocaval junction, 4 at IVC, and all of the above. Which one is appropriate?
All of the above.
Yeah, it is all of the above. Because you need to place above the diaphragm any position. Ideal position would be your atriocaval junction. What is the normal level of insertion of UAC? 1 between T6 to T9, 2 between L3 to L5, both 1 and 2 or none of the above. What do you think is an appropriate answer?
T6 to T9, ideal.
Now, you tell me where exactly is the catheter. You can see the catheter, your UAC, which has gone all the way up. So this is your, what is this?
It entered portal
It has gone
canal.
into the pulmonary veins through the foramen vein, has gone into the pulmonary veins.
It's in normal position. It's in right portal vein and subclavian artery. So this, whatever I'm showing is the complication which can arise because of too deep insertion of catheter and too low insertion of the catheter. This is directly into the left atrium. You can see here. Left ventricle, sorry. So here you can see everything is curled up and you can see features of NEC with dilated multiple bubble loops. So now moving on to the umbilical catheters, you need to have a normal anatomy idea, physiology, variations, and the uses. What do you do when you place a catheter from umbilicus? You go into the umbilical vein, portal vein, ductus venosus, and then into the inferior vena cava. The tip should be ideally lie above the diaphragm, or to be very precise at the level of cavo-atrial junction. That is where IVC joins the right atrial junction. We'll show it in the video. So if it is too long or too short, you will have problem. And it can be very, very severe problem. If it has gone into the heart and if it has damaged the endocardium, it can lead to thrombus formation, features of endocarditis, and it can lead to a lot of complications. If it is in liver, it can lead to hematoma, it can lead to damage of liver parenchyma as well. So you have to be very careful about the exact position of the UVC and UAC. This is how it looks like: umbilical vein, then you have your left portal vein confluence, and then ductus venosus, and then it goes inferior. So number of studies has been done. What is the ideal level of vertebra where if you place, it's which one is accurate. This is the study which is done in 1995, where they found it T9 would have been the most appropriate position to place UVC. As I said, which I'm not going to talk on too deep enough, or not too deep enough. These are the complications. What are the views? We go for subcostal view, parasternal short axis view, and apical 4-chamber view. I always told you in radiology, two different views are important in order to confirm the position or any finding. Do not jump with only one view and say that it is in a position, because the reverberation or reflection of the object can falsely give you an idea about the false position of the catheter. Subcostal view, this is your inferior vena cava and atrial junction. Here I have marked it here. This point and this point is an ideal point. Here the catheter is here. So ideally it should be pushed further till here. This is your target zone. So this is how you do the subcostal view. Marker is placed towards the head, place it here and try to identify your inferior vena cava. And then the catheter. Catheter is seen as a two line. This is your catheter. So ideal position to place it here is, this is the ideal position. I'm sure you are able to see. So this is how it looks like. So it is almost going in. Yeah, you can see here. This is the position. So ideally, this is in position. So this is the real time. We are pushing the catheter, and then we are seeing in ultrasound how the catheter is moved. First, identify your vena cava and the atriocaval junction. Then try to follow the catheter over there and try to push it. So you can see here clearly the catheter started coming. So if you push saline, you can see the movement as well. So catheter started appearing here. So you can see here, this is your catheter. We are pushing, we are pushing, we are pushing. You can see the heart. You can see your right atrium. We have pushed, and it has gone into the heart right now. It has gone into the heart. So it is in right atrium right now. So now we need to pull it back and to place it in atriocaval junction, that is here. So we are pulling it, we are pulling it backwards. This is the real time what we are doing, the placement of UVC. Yeah. So now, yes, this is the position. Yes, this is what. Now parasternal short axis. So how does it look? So your marker should be on the left shoulder, and you start seeing the image, ultrasound image. So this is the thing. Center you have your aorta, then this is your right ventricle, then your right atrium and left atrium. So when it comes, the catheter will come like this. Moves. You can see this is your catheter. This is your catheter. This is the catheter which has gone into left atrium. You can see the structure here. So when you place on short axis, you are placing your probe right below the right ventricle. Below the probe, you have your right ventricle, and then you have your right atrium, and then posterior most your left ventricle. Left atrium. So the apical four-chamber view. So we've inverted the image. This is the probe point. So it has gone like this. So from here, if you see first ventricle in the apical.
hemoglobin blood test report
in ultrasound, you can see these two lines. It has gone into the left atrium. It has gone. This catheter has gone into the left atrium. So it is important that you do subcostal view, apical four-chamber view, and parasternal short axis. So, course of umbilical artery, I'm sure you have got a brief idea about UVC placement and how you do it. Course of umbilical artery, anterior division of internal iliac artery, then common iliac artery, and then you place it in the aorta. Here you need to remember one thing. There are two positions. We keep at high position, T6 to T9 and L3 to L5. Why we don't keep it between T10 to L2? Because that is a point where you have your celiac trunk, you have your supramesenteric artery, inframesenteric artery, and renal artery. These are the vital arteries. If because of the position, if there is a focus formation, or if you damage, or if you block it with this main structures, it can lead to severe complications like gangrene. All the structure which usually it is important that place it T9, T6 to T9, or below L3 to L5, not between T10 to L2. That you need to keep in mind. This is how it looks like. Sorry. Initially, UAC goes down and then it comes out. And then you place it between T6 to T9. Please remember this, T6 to T9, because you are having problem here. So you need to bypass these structures because these are all vital structure. Okay, so we have next, this is what I was talking about. This is your low UAC and this is your high UAC. This is your L3 to L5 and this is your T6 to T9. So I hope it's very clear where to place it. If it is too deep or not too deep, it can lead to complication. Now coming to the case. This is a 26-weeker with RDS. UVC is placed at T9 to T10 and then you have placed UVC. You can clearly see here, and this is your feeding tube, which is in stomach. So in X-ray it looks fine, but ideally it should be above diaphragm. Let us see in the ultrasound what happens in ultrasound. It's playing. Okay. One second. Yeah. So this is how it looks like. You can see in parasternal short axis, you can see the catheter has gone into right atrium and then it has entered the left atrium. Clear? Clear? You see this? So in X-ray, it showed a different position, but when you actually did ultrasound, it showed a different position. So here you can see UAC and UVC. This is your UVC, which is at T10, and UAC at T7. This is your umbilical arterial catheter. This is your UVC. So let us see in ultrasound, where does it look? So this is your atriocaval junction. So it looks fine here, but let us see in parasternal short axis. You can see here it has gone into the left atrium. So that's why I said two plane radiography images are important when you're doing this in an ultrasound. Two position ultrasonography needs to be done. So case 3, 30-weeker, 1.3 kg UVC, you can see it has gone up it is at the level of T9 to T10. So let us see in ultrasound where exactly it is. Yeah, you can see even this the level into the left atrium. So if you, as I said, you should not damage or block the main arteries of abdominal aorta, celiac trunk, supramesenteric artery, inframesenteric artery, right renal artery. So position is very important. There are a lot of evidence which I'm not going to talk about. There is no doubt, there is beyond doubt that role of ultrasound, and it's going to be new norm. And every NICU already, most of them do have, but they'll start using for everything from now on, and it'll all save time. There are a lot of studies which have come up. These are the few images which I've put, and it prevents the major complication. Now coming to the PICC line. So either we use basilic vein or we use the cephalic vein. So how you need to place a thing? First, you need to adduct the arm, and then you need to place the hand over the opposite shoulder tip of the baby, and then you measure the length, because when you extend the arm, there is a chances that it can either go too deep in. That's why measurement of length where it needs to be inserted is very important. You place it in superior vena cava. So suppose if this is the ECG, which also can give you a clue about if there is if no evident P wave or absent P wave changes, which indicates that catheter is not in acceptable position. P2, you can see that P wave is peaked. So this maximum height will indicate that catheter is in the lower 1/3 of the superior vena cava, the right atrial junction. In 3, you can see there's a truncated second half of the P wave is truncated. So this indicates that downward deflection on the leading edge of the P wave indicates that catheter is entering into the right atrium. Then you have a biphasic P wave, indicates catheter is within the right atrium. You have inverted P wave, indicates the catheter is approaching the right ventricle. So this is, you can actually try to see even in ECG as well. So this is, I'm doing the lower limb PICC line has been put. I'm placing the catheter. You can see the position. You have to adjust accordingly till you get that bifurcation of the abdominal aorta. I'll show the bifurcation of the abdominal aorta. You can see here bifurcation of the abdominal aorta. That is your common iliac artery joining into the left and right, joining into the abdominal aorta. Then you need to follow this and try to follow the catheter tip. So this is what we have placed. Superior vena cava, it has come and reached near the junction, atriocaval junction. This is your IVC. This is the ideal position, what we were telling. This is the right atria, and this is a position which we kept the PICC line. This is UVC, a few of the things which I have put. And upper limb, when you put, ideally it should be between 6 and 7 position. That is an ideal position. If you go too deep, it enters into the, this is the marking where, the position which can lead to complication, or it indicates too deep or too not deep enough. So ideal would be this position, 5, 6 and 7. So this is the thing. You can see your PICC line, upper limb PICC line has gone reverse backwards. So this has gone into the carotid artery. So all these are all malposition. You can see it has gone into the right ventricle. These are all malposition of the catheter. Now coming on to the most important topic, that is the pneumothorax. So this is a case. This baby was admitted in our NICU, 30-weeker, normal vaginal delivery, cried at birth, had respiratory distress, requiring CPAP, not maintaining with optiflow, and without saturation fluctuating, and baby had this cry. I hope you can hear the voice. Initially, the saturations were maintaining, but baby was totally in discomfort. You can see lack of chest movement here. Baby is really uncomfortable, and CPAP is actually worsening the pneumothorax. So immediately we intubated and we did trans-illumination, and you can see the glowing up of chest, but this may not be 100% accurate. And then got an X-ray done, which had pneumothorax. The entire process took almost for us to get into this. It took more than half an hour. So if you have ultrasonography or ultrasound machine, you can actually, initially it is a little difficult until you try to get the anatomy, ultrasound anatomy in your mind. Once you get it, you can actually do it within 15 seconds, a maximum within 10 seconds. You can diagnose your pneumothorax. So emergency sonography in pediatrics has become one of the most versatile modalities in diagnosing, in management of many things, not just pneumothorax. So these are the few things which, guidelines which clearly say that, ultrasound is far superior. How do you do ultrasound of the chest? Anterior axillary line, you place horizontal and sagittal. Then you come to mid axillary line, horizontal and vertical, and then posterior axillary line, horizontal and vertical. On both the sides, you need to do it. So what are the things which you look at when you are doing the
normal finding of a lung?
What you are looking at? You are looking at this is your rib shadow. This is a rib shadow. As I said, zone 1 above the pleura. This is your chest wall. I'm sure you can see the chest wall. This is your pleura, and below the chest wall, you see lung parenchyma, and you can see the shimmering or ant moving, or this is called lung sliding. So anatomically, if you see, there are 2 layers of pleura, the parietal pleura and visceral pleura. Visceral pleura is stuck into the lung, and parietal pleura keeps sliding. So with very high frequency probe, you can see the 2 layers, but generally you see as a single line and a shimmering effect. With you can short comet tiles you can see here. This is your chest wall, this is your rib, and this is your lung sliding. You can see a short comet tiles. So this is your normal lung sliding. I'm sure it's clear. You can see the shining here, short comet tiles. Yeah, in M mode, if you do, this is your pleura. Above the pleura, it looks like a C, and below the pleura, it looks like shore mud. It's called C shore. C Sure. That means above pleura also is moving, below pleura is also moving. When it moves, you see this like a mud or a sand-like appearance. It's called seashore appearance. So when there is gas, this is for the normal lungs line. This is the short cometal which I was talking about. Short cometal. This is your first chest wall, zone 1. Then pleura is your zone 2. And below pleura is your zone 3. So this is your parietal pleura, what you see. Visceral pleura is adherent to the lung tissue. This is your short comestal, the shining thing when lung is sliding, you see this. I'm sure it's very clear. Now let us place a probe sagittally over the lung. See, I'm sure you are able to see this. And then this is one rib, this is another rib, and you see nice, this the movement. You can see the movement here, pleural lung. Yeah. So you have a blue line and a red line. Blue line indicates your parietal pleura, and red line indicates your visceral pleura. So when both of them rub each other, you get your lung sliding sign. And that's an important marker when you are diagnosing. Okay, I'm sure lung sliding is very clear for all. This is okay. So this is the pictorial representation of soft tissue versus ultrasound image. You can see clearly what I was talking about. You have your ribs, and below the ribs, because ultrasound does not travel through air and bone, so you can see a shadow. And then you can see your pleural line, and above pleural line you see your soft tissue, and below soft tissue you see lung. Below pleura you see your lung parenchyma. This is exactly it looks like. So so we need to look at all this thing, between the thing. Now we are coming to, suppose if there is an air between the pleura. If you can see an air in between the pleura, that means air is a bad conductor of ultrasound. So when you place a probe, one is the visceral parietal pleura and visceral pleura separated, so there is no lung sliding. You just see one thin line, no shimmering movements, no ant-like movement, no sliding will be there because there is air in between, and below this you don't see anything. So this is how it looks in ultrasound. We can see here. Hardly you see any lung movement. You can see. Just it is moving, that's all. It's not sliding. It is not sliding. If it is sliding, you get your short comet tails here. So you can see here as well. Just one line which is not moving. It's not moving. So when you do an M mode, which I was talking about, see below the pleura, the lung is not moving. It is blocked because of air in between the pleura. That's why you see only above pleura what you see are horizontal lines. It's called barcode sign. There is loss of sand or shore sign. So you place a probe. There is a pneumothorax here. So this is the red line will come here, and the blue line will come here, separated by the air. So there is no lung sliding. So when you see at the ultrasound, you can see here there is no lung sliding. Otherwise, it will move and you will have short comet-tails here. There is no lung sliding. Barcode sign, which I was talking about, this is what it looks like. Now, lung point. What is lung point? A point if there is a partial pneumothorax where part of the lung is moving and part of the lung is not moving. So you place a probe and then you slide it across and see. You see lung sliding. At a point you will see where the lung, you can see here, with the marker which I'm showing, there is a lung sliding here. See clearly there is a short comet tails, the lung is nicely moving. Now you see it's coming and stopping here. See it's coming and stopping here. This is the point where there is air which is blocking the lung sliding movement, but other part of the lung is moving. That is called lung point. That's a 100% sensitive for your pneumothorax. Then if there is absence lung slide, we look at that can be a differential diagnosis for many things like pneumonia, consolidation, pneumothorax. So when you go into the M mode and absence of lung pulse in 2D mode when you do, 2D mode when you do, you need to go into the M mode. So in M mode, if there is a pneumothorax, you can see here that there is, which I had shown in my earlier slide, with every pulse, you see the lung pulse, it is called. You see that vertical projections, but in pneumothorax you don't see that. So presence of lung point clearly differentiate between with absence of lung sliding and presence of lung pulse clearly rules out pneumothorax. So this is how it looks like. See here, with every beat in the red mark I have given, equidistance, you can see the lung pulse in M mode. See, if there is consolidation, if there is atelectasis, if there is pneumothorax, you don't see lung sliding. And here you can see here, see this part is consolidated. Okay, this part is consolidated and you see the horizontal line, but this U-shaped part is fine. So lung pulse is basically with every heartbeat, you start seeing this. In pneumothorax, you don't see this. It won't be conducted. So lung point is an 100% accurate for your pneumothorax. So this is how, for example, so you have placed the probe here. Suppose you think there is a consolidation here. From this is the heart. So when you place a stethoscope here, you hear the heartbeat, correct? You hear the heartbeat like this. Suppose if there is consolidation, the lung pulse you see in M mode, because as I shown earlier, if there is air in between the pleura and in pneumothorax, that is not at all transmitted even in M mode. So this is what I'm showing, the pneumothorax or the lung point. Yeah, you can see here the lung sliding is coming and stopping here, coming and stopping here. This is how it looks like, coming and stopping here. This is your lung point. This is a characteristic and hallmark for your pneumothorax. There is a lung point and there is lung pulse. Absence of lung pulse goes in favor of pneumothorax. Presence of lung pulse with each beat in M mode, if you see lung pulse, that goes against the diagnosis of pneumothorax. Lung point is 100% sensitive for pneumothorax. Now role of Doppler in pneumothorax. So in pneumothorax, when you place a color powered Doppler or a color Doppler when you put with different velocity, you set it at 18 centimeter per second, you start seeing the few lines around the pleura. Then you decrease the velocity to half of it, 9. Then you start seeing almost 2/3 of the parenchyma. Then you reduce it further to 3 centimeter per second. You see the entire, the parenchyma shows the color. So this is not seen in pneumothorax. Now this is the roller color Doppler. You don't see anything, any color, not much color here. So this point where you are seeing color is your lung point, and lung sliding is also not there. This is a characteristic of your pneumothorax. You can see one more time. There is no lung sliding. There is no lung sliding, and color Doppler also you can't see. Color powered Dopplers. Now we move on to the. See here you can see. Yeah. See, you can see here the entire this portion has become colored, but this is the lung point, and you don't see any color in this particular thing. This is your lung point with color Doppler, and this is also one of the additional marker for diagnosing of pneumothorax. Now let us see the lung sliding. Can you see the difference? The entire this particular box, what we have kept as. See here, it has increased. So they have put a chest tube, and once the air is drained out, you can start seeing with the color. This is how exactly it looks like. So with color powered Doppler, this is how it looks like. You can see entire lung parenchyma is totally colorful and covered with color. So this is the role of ultrasound, which can also be, which has not been put as a marker, but which is coming up as one of the most important marker. In addition to lung sliding, in addition to lung point, lung pulse, and color, Doppler. So absence of lung slide differential diagnosis already I've told you. and sensitivity wise also. Approach, first you look at the lung slide. Start, you place a probe and you see in between the probe, in between the rib, you see the pleura. Look at for lung sliding, absent lung sliding, then look for A lines, that is the horizontal line. No, if it is there, if there is a lung point, 100%, as I said, lung point is a 100% sensitive marker. If there is no lung point, you need to consider other diagnosis like consolidation, atelectasis, or you need to look at other causes of absence lung slide. Take home message, let us not be blind, let us all open our eyes, guide the catheter, no radiation, no hazard, safe, quick and more accurate. Till you hold a probe, you will find it like totally alien and different, but once you hold a probe, start learning. So I would like to wish all of you a happy International Yoga Day. Keep up your health. And thank you very much for patiently listening to such a long lecture. Thank you, thank you, thank you.
Thanks a lot, Dr. Prashanth.
Yeah, thank you, thank you, thank you.
Sorry, Dr. Kishore, did you want to say something?
No, I just wanted to congratulate for such a brilliant lectures from both of them, and I'm sure there will be a lot of questions. Definitely, they made the subject look so simple, but it may not be simple without a good amount of training and practice. And that's all I wanted to say. Thank you, both the speakers.
Thank you, sir. Thank you, sir.
Excellent presentation, Dr. Prashanth. So the graphics and all the videos made it so interesting. I learned a few new things today. Regarding the questions.
Yeah.
Prashanth, any messages you have got? Or?
Yeah. Just check your WhatsApp, no? It's
Sure.
written and sent.
Sure.
Just check
so
your
I think Dr. Tushar is also online. Dr. Tushar, are you online?
Dr. Tushar?
Dr. Tushar?
Dr. Tushar, yeah, he's there. Dr. Tushar, can you unmute yourself? Yeah, I think he has come up.
Prashanth, maybe I will direct this question to you.
Yeah.
I think, no, this is from, this is from Dr. Tushar's talk.
Yeah.
So how to differentiate collapse from pneumonia and collapse from bronchial obliterative pathology? Dr. Tushar, this question for you. Could you please?
Dr. Tushar, are you there? Dr. Tushar, please unmute yourself. I can see your name. Can you please unmute? Can you unmute, Dr. On hold, yeah. Tushar has come. Dr. Tushar, sure. Yeah.
Can anyone hear Dr. Tushar? We
Can
can't
you
hear.
see me? Can you hear me?
I can. I request all the participants.
Can all the participants kindly mute their audio other than the speakers?
I'm going to mute all. Dr. Tushar, you unmute yourself.
क्या हुआ है?
Yes,
Yeah.
Dr. Tushar,
Yeah.
you can unmute
Yeah.
yourself. Yeah.
Yeah.
Yeah, go ahead, Nilesh. Dr. Nilesh, please unmute yourself and go ahead.
Dr. Tushar, can you hear me? Did you
Yeah, I can,
hear
yeah.
the
No,
question is
uh-huh.
how to differentiate a collapse from pneumonia and collapse from a bronchial obstructive or obliterative pathology.
Correct. Correct.
Collapse, atelectasis versus pneumonia.
Correct. It's
I
a
think
very
you
good
had
question.
touched upon it, so maybe you can just maybe give us the points.
Yeah. Now, see what happens in consolidation or pneumonitis. You have a tissue like there are many other signs which are corroborative signs as well as direct signs. So, as far as the direct signs is concerned, it gives a tissue-like appearance, presence of thickened pleura, presence of C lines, presence of increased vascularity, presence of thin pneumonic effusion. All these signs are pointing towards consolidation. And when you have collapse, and in consolidation, you have dynamic air bronchograms, wherein which the tissue is there, and within tissues there are tubes, channels which are filled with fluid. However, with breaths, there will be entry of air, and that entry of air you will see. I have shown that videos where you will see those dynamic air bronchograms. The branching is seen, and the air which is going and coming out will be seen as a bright shadows. As far as the collapse is concerned, collapse basically there is this branching of the bronchi. They will be seen crowded, and arboriform pattern which is crowded, it will be seen, and other signs of consolidation are missing from there. So many times you will see. So basically, crowding is one of the important clues, and basically crowding is more important clue towards taking you towards collapse. And presence of dynamic air bronchogram will be pointing towards consolidation. In case of collapse, again, there is no air entry, so you will not be able to see this dynamic pattern as far as the collapse is concerned.
Thanks, Dr. Tushar. Coming on to the next question. So, lung ultrasound and severity of RDS. I think in this talk you did not talk about RDS. So, do you want to take that question?
No, I spoke. See, again, as I said, a lot of, as I said, see, the lung ultrasound has come in neonatal practice from adult medicine. And generally, we are, as far as the neonatal practice medicine concerned, we are generally about 10 years, 15 years behind adult medicine. A lot of things, if you see. So, in a lot of practice, as far as the pneumonia, pleural effusion, their management with the help of ultrasonography, behind. So there are certain neonatal lung pathologies which we have not been able to characterize as far as the ultrasound is ultrasonic tests are concerned. Amongst all, say for example, how does the lung look in meconium aspiration syndrome? How does it look in chronic lung disease? How does it look in another interstitial emphysema? All these things still need a lot of characterization. There is no.
Dr. Tushar, unmute yourself, Dr. Tushar, please.
Yeah. So yeah. So as far as these lung pathologies are concerned, say for example, meconium aspiration syndrome, chronic lung disease, pulmonary interstitial emphysema. So many of these lung diseases are there where there is no specific characterization which has happened. So as far as possible, as RDS is concerned, RDS has actually been characterized. There are a good number of studies which have come up in last 4 or 5 years. And all the studies, they show that there are certain factors which are uniformly seen in RDS. Number one, there is pleural line thickness. Number two, there is increase in water content. There is more B line and confirmed B line and whiteout pattern. In our study also, we could see whiteout pattern in the lungs. And we've done a study, Dr. Anukul in KM, our student, he has done a study where we found out that the lung water score is more, and we've been able to show that the lung water score has good correlation with severity of RDS, need for surfactant therapy. And these are the features. But again, as I said to you, there is no diagnostic pathognomonic ultrasonographic feature as far as the neonatal RDS is concerned. As against say pneumothorax, Dr. Prashanth spoke, there are certain pathognomonic features. And there are many neonatal disorders, this is pathological conditions which need more studies to kind of have ultrasonographic characterization of those diseases, basically.
Thanks, Dr. Tushar, for the thing. Like how do you differentiate between RDS and TTN in neonates?
So again, this is a very important question, and we do quite often for RDS and differentiating between TTN. And in fact, I showed that case number 3 where there was this like 36-week gestational diabetes and baby had distress after birth. Now this is a common scenario. In that scenario, RDS, we need to remember that RDS is a uniform disease in entire lung fields on both the sides, as against and it is a RDS is a and TTNB is a disease which is more so there are specific signs for TTNB. There is a double lung point wherein which the gravity dependent lung segments, they will show more water and they will show confluent B lines as against areas. So you have to use a linear transducer, place it in the axilla, and the upper lung fields will show you presence of A lines and the lower lung fields will show you confluent B lines, as if you are looking at two different lungs in one frame. That will tell you that there is a double lung point is a very, so Copetti et al. They have done this studies and they have come out with this, so that double lung point specifically suggestive of transient tachypnea of the newborn. However, in our studies, we had I think couple of patients where transient, they also had a double lung point and they clinically turned out to be RDS. So the Copetti et al. And they have said that it's 100% specific for transient tachypnea of the newborn, but we have to, like in our own studies, like we saw 2 patients who had this, but clinically, because see, finally diagnosis of RDS depends upon clinical course of the disease, X-ray pictures, and overall clinical course of the disease. So so double lung point is something which is very specific for, it's predominantly very specific for transient tachypnea of the newborn. And as far as the neonatal RDS is concerned, the disease is uniform in all lung fields. You will have a similar picture of pleural line thickness, presence of more B lines, and whiteout lung fields, basically.
Thanks, Dr. Tushar. One more question. So, with kind of in the context of COVID-19, they're saying just in case babies start coming, how do you differentiate an infarct in the lung from consolidation in the lung by lung ultrasound? So this is a pediatric intensivist who has asked this question.
Oh, right. See, absolutely, to be very honest, we do not have absolutely any experience in diagnosing lung infarcts on lung ultrasonography. I guess, I mean, there will be non-uniform and asymmetric lung fields on both sides, presence of more of lung. Actually, to be honest, I have no experience about diagnosing pulmonary embolism or infarcts on lung ultrasonography.
Would Dr. Dinakar want to comment on this? Dr. Dinakar or any other expert?
No, dear friend. Yes, boss. Yes, boss. Don't worry. Dr. Tushar, it is simple, very clear. I think so pediatric intensivist, what he has asked is correct. Because now COVID is there. We know that why the people are hypoxemic, happy hypoxemic, sudden death. It's because of the vascular thrombosis. Probably that is the reason he might be asking. See, number one, pulmonary infarct either in the adult, either because of the DVT or any reason, or if it is a children because of like a Kawasaki disease or because of the thrombosis, if the thrombus enters into the lung, it is exactly like a wedge shape or V shape, because that infarct will go and stuck into the either one segment from the pleura to the whichever the proximal means the proximal artery, wherever infarct is there, wherever that supply is there, it will be like a what is it, one wedge shape or V-shaped infarction will be there. But if it is in the, if it is like a consolidation, it will be like an irregular. Number one, irregular, very clear. Irregular margins in the consolidation. Very clear V-shaped or wedge shaped it is in the infarct. There are so many articles are there how to differentiate between pneumonia and infarct in the adult side. And once again, thrombus like protein S, protein C, what is the deficiency, what will happen, how the infarct will come, or polycythemia causing infarct. Otherwise, air embolism with the pneumomediastinum causing embolism, how it was looking. There are 4 articles in a neonate. How it was in ultrasound lung, it is looking. So wedge shaped or V shaped and irregular border. Thank you. Over to Nilesh.
Yeah, thanks, Dr.
I'll
Dinkar.
just have one comment,
Sorry,
Nilesh. Sorry.
Yeah,
Sorry.
yes.
So, see, when this actually want to tell about like lung ultrasonography. Like, see, every disease has a specific a diagnostic test or diagnostic modality. Because see, if there is a child with perinatal asphyxia, we cannot diagnose perinatal asphyxia based on lung ultrasonography. But lung ultrasonography is a diagnostic modality to diagnose intraventricular hemorrhage. So similarly, for lung ultrasonography also, we can use lung ultrasonography for each and every disease in the lung. But ultimately, what I feel and what is there still is that there are certain diseases in the lung wherein which lung ultrasonography is kind of a will clinch the diagnosis or will seal the diagnosis or will be kind of a life-saving modality. So every modality we have, I think we have to use it to their maximum strengths. That is how we will have to look upon it. Like, say, for example, can you diagnose meconium aspiration syndrome based on lung ultrasonography? The answer is no. Can you diagnose pneumothorax? The answer is yes. Can you diagnose pleural effusion? Yes, the answer is yes. So every modality will have its own strengths and weaknesses, and we have to harness and use those strengths to diagnose a particular condition. That is what my thing is. So we have to take only that. So we cannot take the negatives, but we take the positives of every modality.
Sure. Thanks, Dr. Tushar. Also, one more question. How do you differentiate C lines and Z lines?
Yeah, so I think, see, Z lines, I think they have described it in the peripheral lung fields, and I think they are more suggestive of this. They are correlates of pulmonary edema, and we are not actually Z lines. I am not familiar of diagnosing and using. I think, as I again said, the lung ultrasonography again itself, there are many things which are there, and we are using is those which are this thing. So C lines we are seeing very often, very commonly. Z lines not so often. We are not used to kind of seeing and diagnosing and managing. Maybe Dinkara can highlight.
Yeah, one small addition. Nilesh, can I add, my dear?
Sure, sir.
Okay. Dr. Tushar, thank you. See, what you have already told about the C lines. What is the C lines? You told very clearly what is the C lines. So, what is the Z lines? Z line is just above the pleura. If you are seeing any comet tiles like just above the pleura. If you are seeing subcutaneous emphysema, means air outside the what is that in the subcutaneous tissue. Number 1 word. So reverse comet tiles above the pleura, if you will see that, it is Z lines. Very clear is over. So C lines, as you told very clearly, that is same thing. Sir, next. Nilesh.
So, Dr. Tushar, how can you quantify pleural effusion, the volume?
Yeah, so there is actually, see, the volume diagnosis again in the newborns, it is not very it is erroneous. But in case of adults in bigger age group, so the distance from the chest wall to the outer border of the pleura, the lung, multiplied by, there is some formula, I think it's multiplied by 4, I think 40. So that will be the lung volume. But in the newborn, there is no such equation actually.
Yeah. So, Nilesh, what Dr. Tushar was telling is a very correct. So, whatever the distance, even it holds good in the pediatric, but none of the studies are there in the neonate, and people have tried to do the study in a neonate with the chylothorax or anasarca babies or fetal hydrops babies to quantify the fluids, but none of the things are published, but it is not so correct. Number one, what is there in the pediatric is let the baby or patient sleep. So lie down, then keep your probe perpendicular to the lateral border of the chest. Perpendicular to the lateral border of the chest. So posterior portion of the thorax and posterior portion of the lungs. Whatever the fluid collection, you measure it perpendicular. So posterior, when the patient is lying down, fluid will come back. So posterior portion of the lung and posterior and anterior portion of the, what is that, thorax cavity into 20 into example millimeter. Suppose if it is a 20 millimeter, 20 into the whatever the ml, so 20 millimeter is there into 20. It is 400 ml. So that is called Belinic formula. One more is Goic formula. Another is Iberic formula. There are so many formulas. All those things are well good in adult and pediatrics. Nothing is well versed what Tushar has told in a neonate. So you can still quantify the formula because pleural fluid is every hour per kg is 0.01 ml to 0.05 3 ml it is produced. So normal fluid, pleural fluid is 0.5 to 4 ml. It will be there always. Thank you. Over to Nilesh.
Yeah, I think in neonatology, we don't give as much importance to the volume of fluid probably, rather than like probably we want to tap it and see what kind of fluid or whether it is causing any effects on the lung. So I think that can be figured out through other ways. So anyway,
so we have sorry to interrupt.
Yes, Dr.
So
Tushar,
we've
sorry.
seen we've seen many, actually because of the want of time, we have another couple of cases wherein which the child is severely hypoxemic. You are struggling. That there is underlying pneumonitis, like the meconium aspiration is there or pneumonitis is there, and then you find out like pleural fluid which is causing underlying collapse of the lung, and the quantity may be 15 ml, 20 ml, depending on the size of the baby. And if you tap that, and we had so many cases wherein which we just tap that fluid and that has improved oxygenation. So hemodynamic significance, oxygenation significance, that is more important as against the volume. But yes, actually, I mean, one can do studies as per the weight of the child and whether the distance holds true in terms of quantification of the volume. Yeah.
Thanks, Dr. Tushar. One more question. They wanted some clarity on the spine sign, the mirror sign, in pleural effusion. So they wanted one more explanation from you.
So what I understand is that normally when with the sonography, when we are doing sonography from the flap point, generally the diaphragm is there, and there is the lung recess which intervenes between diaphragm and the chest wall, and beyond that there is liver, and beyond that you will see the spine. So basically when there is pleural effusion, then there is because of the lung, if it contains because it contains air, there is the ultrasound beams cannot traverse it, and one will not be able to see the spine very clearly. But in case when there is fluid there, and then when the ultrasound beam can traverse this pleural space clearly, and then you are able to see the vertebrae very clearly. So that is what my understanding of the spine sign. Yeah.
Yeah, thanks, Dr. Tushar. I think for Prashanth.
Yes, I'm there. Please go on.
Excellent presentation again, both the speakers. I think one of the things is people wanted one of participants wanted to know about lung pulse. So could you please talk about lung pulse again? What is lung pulse and where is it seen? Where it's probably not seen also. Could you please give clarity on that?
See, basically, when heart beats, you take a stethoscope, put it on the chest. From heart, the heartbeat is transmitted to the surface, and you hear the heartbeat. Same way, with every beat, the lung also, the lung pulsation is seen. Typically, if there is a pneumothorax, if there's a gap between the parietal and visceral pleura, this sound is not conducted, and lung pulse won't be seen. This is ideally used, to differentiate between the whenever there is absent lung sign, because absent lung sign is a marker of pneumothorax, consolidation, atelectasis, and other. I've mentioned the differential diagnosis. So, if there is presence of lung pulse, that clearly rules out pneumothorax. If lung pulse is there, you need to look at other cause other than pneumothorax. Basically, it's a movement of lung with every beat of the heart.
Thanks, Prashant. See, one question from a DM neonatology resident. So they don't have a linear probe in their hospital. So his question is, can they use a phased array probe for lung ultrasound? And also the probes that can be used.
They can use any probe, preferably high frequency probe, because when you're looking at especially when you're looking at the chest and even in the neck, the higher the frequency, the superficial structure looks better. But however, you can do any probe. Basically, you need to have a basic idea about the ultrasound anatomy, what exactly you are looking at, and so that is what we are looking at. They can do with any type of probe. That should not be a problem. Ideally, if they have frequency between 5 to 8 hertz, they can do the lung ultrasound. Even Dr. Daniel Lincoln with a very simple machine. The images are, it's 1979 Fujifilm some machine. So you need to have an idea what you are looking at. Yeah, Dr. Tushar, you want to add something?
Yeah, actually, this point actually I also covered in my first part of the talk. Basically, you have a dedicated pediatric probe which is around 7.58 megahertz, and generally we are also using the same probe for head ultrasound, cardiac echo, and that is good enough for pulmonary pathologists. Some of the signs which are specifically described, say double lung point, or say for vascular access, Dr. Prashant covered. So there you require a very high intensity, high frequency probe. But most of the other work, most of the routine work, even the lung ultrasonography, especially the flap point, which is there, which you have described, they were described with a sectoral probe. So a dedicated pediatric probe is good enough for day-to-day kind of routine work, and very specific indications will be there for a linear high frequency.
Another question is probably for Dr. Tushar. The utility of lung ultrasound in congenital lung abnormalities. I think he's talking about CLE and CCAM and all that in the neonate.
Yeah. No, I think again, as I said to you, as I think Dr. Prashant also covered and Dr. Nilesh also said at the beginning, is basically the applications of lung ultrasonography are increasing by day. Currently, as I said, it is still an evolving science. Even when we started doing point of care echo and ultrasonography, lung ultrasound was not there. We added it in last like 7-8 years. So we have not been able to characterize the regular neonatal illnesses as of now. So if somebody asks me, the ultrasonographic picture of say pulmonary interstitial emphysema or ultrasonographic picture of meconium aspiration syndrome, is there anything diagnostic? So we have not that still there is we need more literature, and leave aside the like anomalies, there is still long way to go. But of course, yeah, I mean some anomalies like even one can assess the function of the diaphragm. If there is unilateral, if there is asymmetry, so congenital lobar emphysema is there. So on that side there will be more A lines, there will be less B lines, and the signs of hyperinflation is there. As far as the foreign body is concerned, then there are studies to suggest that to see if there is a one can detect foreign body is acquired condition, but that can be detected, or even in absence of lung, that side one can assume, because there are not so many studies to kind of characterize all of these diseases for us to kind of comment basically. Even in diaphragmatic hernia, one can see. The other day I was doing echo and we had one patient echocardiography, and the diaphragmatic hernia was missed, and I saw the heart was resting just next to spleen and there was no diaphragm on that side, and then it was referred to me for echocardiography basically, and then the x-ray was seen, and then there was a doubt, and then they proved that there is no diaphragm on that side, and it is a diaphragmatic hernia. The spleen had come up in the chest. So every now and then you will see such things. Yeah, but to kind of concrete characterize, still we require kind of a set number of patients, like 30 patients with diaphragmatic hernia, and their ultrasonographic picture looks like this. Like this is still not there. Yeah.
Thanks, Dr. Tushar. One other question. Can you characterize the severity of respiratory distress syndrome based on the B lines? I think rockets,
so
AIS, and all that probably. Yeah.
The people have done that. There are studies, and what we found in our studies, basically the lung water score we used as a marker of like whiteout. X-ray wise, we know that grade 1, grade 2, grade 3, like RDS severity. So in our study, we found that the lung water score correlated well with severity of RDS and need for surfactant therapy. That we said there's a more severe RDS, more need for surfactant. That much we could show on that. As far as the progress of those illnesses in terms of development of chronic lung, in terms of mortality, that it was not significant. But again, that we need to again study such things. There is a lot of scope of use of lung ultrasonography in these patients, whether you are using optimum PEEP, whether you are using CPAP pressure, which is adequate or not, whether changing CPAP pressure changes in kind of lung. There is a lung aeration score also is there. So whether it changes in the lung aeration score, things like that, you know, and they need to be applied in the neonatal population and validate, and then one can decide whether they can be used longer.
Thanks, Dr. Prashanth, one more. Again, we wanted some clarity on that aortic arch. So 1 centimeter, 0.5 to 1 centimeter. How much distance from the aortic arch for the endotracheal tube?
Yeah, that's what. There are 3 branches that comes out of arch of aorta: innomet artery, your left carotid artery, and your left subclavian artery. In between innomet artery and left carotid artery. So from that point, you take up to. So ideally, if you take 0.75 centimeter, depending on the gestation, there are a lot of studies which are coming up, still yet to come. Then 1.2 centimeter, 1.5 centimeter, like that, it keeps on adding. So 0.8, 0.6, 0.12, like that, they keep on adding. So anyway, so from there, from arch of aorta, you need to place your ET tube. You know, if it is less than 1 centimeter, it is 2. If it is 1 centimeter, is 2 up. So you need to place exactly from that particular point, peak of arch, that's in between the innomet artery and the left carotid artery. 1 centimeter, that is the exact position. So if you keep in that position, that suggests that it is just above the carena. Because I put one picture depicting how, and as they grow older, the length of the trachea also increases. So it won't be same. So as of evidence we have, this is what it suggests. But as Tushar said, a lot of scope to study on this particular, exact on different varying justifications.
Oh, Prashanth, I think there was a recent publication in Indian Pediatrics, I think, no, regarding normative data for this. So that the smaller babies, the distance may not be the same for different gestational age babies, right?
A lot of evidence needs to come. I mean, Gangaram people have done one study that was in, I think, 2016 or 17, I think, 17. So that's what.
All right. I think I have exhausted all the questions. Thanks again for an excellent presentation, both the speakers. I thoroughly enjoyed it. So, Dr. Dinkar, any other comments, Dr. Kishore?
Final.
Excellent. तुषार को I don't want to talk only. अरे यार इतना famous हो गया यार. Very nice talk. Really nice. And
You're the master in ultrasonography of whole body. You're doing sonography of eye. You're doing sonography of fractured rib and whatnot. There is a lot to learn from you all. And I think thank you for inviting me. It has been a wonderful time and really enjoyed this. Thank you very much for having me.
And one more thing is, thank you, sir. Dr. Prashanth, very good videos, very good informative, easy spoon feeding videos. Please put it in the, whatever the web, YouTube, wherever you are putting, please. It will be very useful for all the things. And whatever you have put, the color Doppler and the, power Doppler, CPA. What you have put, it's a really nice videos and it is eye-opening, excellent. Thank you very much.
Can I ask one
Nilesh
question?
हाँ जी बोलिए.
Hello, sir. Hello.
हाँ sir.
Hello, Dr. Tushar, Dr. Prashanth.
Yeah.
Excellent presentation from both of you. And really,
can I ask one question, sir?
Yes, sir. Naresh Prasad, you can ask.
Yes, sir. Can we differentiate between the oligamic lung field and plethoric lung field by ultrasonography?
See again, I mean, oligamic by definition, you'll have less of fluid, less of blood supply, and oligamic and more of air. So they would show up with more of A lines and less and no of B lines. As against plethoric lung field, will be seen something like plenty of B lines, lung rockets, and whiteout lung fields. So this is one can say this lung water score will be more. Exactly what number we'll call it as oligamic, at what number we'll call it as plethoric, still needs studies. But one can get an idea whether the lungs are like flooded or lungs are like oligamic, very less.
Sir, can we differentiate from pleural effusion and empyema in ultrasonography?
Yes, definitely. One of the best modality to differentiate between these two, one of the best available modality is lung ultrasonography, because you will see septation, you will see something called as plankton side, where there is whether the pleural fluid, if it is jet black, which is telling you that it is a low density plain water fluid, plain fluid, or if it is thick, where there is particles in it, you will see them moving. This is known as a plankton sign. And as the empyema progresses, you will see septations and formation of septa and formation of sometimes kind of abscess also. So that you can be able to see on lung. So lung ultrasound is a very good modality for that.
Sir, can we elaborate any foreign body injection which is not radiopaque?
Yeah, so foreign body injection, again, the movement of the lung on the lung slide will be less. The lung pulse will be more evident on the side, which is there is a foreign body, and the air bronchogram. So there are some signs of like collapse. If it is there, if it is in a distant segment, you will be able to see collapse. So some pointers will be there to suggest that there may be a foreign body on that side. Also, the diaphragmatic movement also one can assess that the diaphragmatic movement on the side of foreign body will be less as against the other side.
Are there any center in our country who are giving training for the ultrasonography chest?
I didn't get the question, sorry.
Are there any center in our country who are giving training for ultrasonography of the chest?
Yeah,
any training?
Yeah, so I think center, there is no specific center which will give certified course as such. Dr. Dinkara is conducting quite a lot of workshops and we are conducting. So how we also learned is through attending workshops, reading and going with the experts, spending time with them, defining your skills. Unfortunately, currently this is the only, I don't know anybody who is offering course. So there is a course in Paris, Professor Lankenstein, he is offering the course. And that is again a 1 week course where you can take that course and you can learn ultrasound. But as of now, I don't know anybody in India is offering.
Yeah, so, Naresh Prasad sir. Naresh Prasad sir.
Yes,
if you will go to France and all, you have to spend around 5 lakhs to 8 lakhs. you will come to Tushar Parik. अरे तुषार पारिक तो 2 लाख रुपए ले लेगा.
नहीं नहीं
दे देंगे सर, दे देंगे.
नहीं
नहीं आपको नजदीक तुषार पारिक की
we are
होता
happy
है.
to welcome them. No problem, and we can arrange in the best possible way for their stay also. Yeah.
He is there in the Pune, sir. आपको नजदीक होता है, पकड़ लो. हाँ नरेश प्रसाद सर, क्लोज करूँ क्या?
Sir, please unmute yourself, Dr. Dinakar sir, Dr. Tushar.
Yeah.
You can unmute. Kotreshi sir, you can unmute. Yeah, you can unmute. You can unmute.
Naresh Prasad sir.
Hello, Prashant.
Yes, sir.
हाँ sir, Heli sir, Kotresh sir, please tell.
Hello, sir.
Tell us, sir.
I am really proud that Dr. Prashanth and
Yes.
I am to say he is my secretary for this area of Karnataka. Very nice presentation because ultrasound he made very simple as a examination of the newborn baby. The ultrasound and examination should go hand in hand. Then only he can pick up some of the basic things also in a major things also. Even a measurement, even putting the stat, even the putting the ultrasound. He has given a very good presentation on this system. I am very proud of him and thank you one and all. And I am thanks to both the speakers on nice presentation on behalf of KNF Karnataka.
Thank you, sir.
Nilesh ji, thank you very much.
Thank you.
Thanks, Dr. Dinkar, for clarifying. I think we did not use him enough today. Dr. Dinkar was not used enough for all his knowledge and